I wanted to make a video and explain in really simple, easy terms how we actually see and how ligamentous cervical instability and a condition that I call cervical destructure, where the cervical spine breaks down, how it affects vision. So if you have blurry vision, double vision, you feel like images are still going after you look at them, blurry vision, your blind spot's getting better, or you just have visual problems where the neuro-ophthalmologist hasn't given you an explanation, or the ophthalmologist says everything's good with your eye, you definitely want to watch this video, because I think I'll explain it to you and give you some tidbits of what you can do about it. So sometimes we forget about what the different parts of the brain do. So the frontal lobe, it has to do with reasoning, memory, intelligence. The parietal lobe is part of that, but it's a little bit more emotional. Then the temporal lobe and occipital lobe have to do with vision, but most vision occurs in the occipital lobe. I put this up here because I want to explain how do we see, but I also want to explain, just by knowing the anatomy of the brain, it can help you start thinking about what's actually going on. So the frontal lobe, the blood supply is the anterior cerebral artery, which is a branch of the carotid artery. The parietal lobe, temporal lobes are typically the middle cerebral artery. That's what we measure in the office. That's the main branch of the carotid arteries. The carotid arteries run in front of the cervical vertebrae. So if you have a forward head posture, because you're looking at the cell phones too much, the vertebrae can slip forward, especially the atlas, and you can even get compromises in blood flow to the brain just from the breakdown of the cervical curve from ligamentous cervical instability. The cerebellum and the occipital lobes in the back of the brain, the blood supply is the vertebral artery. As you guys know from previous videos, the vertebral artery actually runs inside the cervical vertebrae. So any type of instability basically can start to kink or cut off the vertebral artery. The way you document that is through extracranial or intracranial Doppler exams, which is an ultrasound, which is one of the tests that we do in the office. What we do is we do it upright, because most people get dizziness or things like that because of the upright position or moving their head in a certain way. So that's when we scan them. When somebody has monocular visual loss, and this is common in migraines, right? When the person gets an aura or during a migraine, they can actually lose vision on one side of the body. Modern medicine has different explanations for that, and the scientific term for that is amaurosis fugax. And then, after a few minutes, sometimes longer, the vision returns. Well, the ophthalmic artery is the last branch of the internal carotid artery. So thinking like somebody who's involved with joint instability, personally, I think that the monocular blindness in things such as migraines or the aura of migraines is because that ophthalmic artery is closing because of joint instability, either irritating the superior sympathetic ganglion, which we'll see later on, or it's actually affecting the carotid artery, and again, then the distal branch of it has decreased blood supply for a certain period of time. Because normally these things occur when a person's upright. Then when you get a migraine, you lay down, and probably the laying down causes the vertebrae to go back. Then there's not so much pressure on the sympathetic ganglion, which of course would cause vasoconstriction or a closure of the artery, and or physical compression of the carotid artery, which is affected by the distal branch is the one affected. So most of the people that come to Caring Medical, they have all kinds of visual things. They have blurriness of vision, double vision. They have where they're looking at an object even though the object is still, but in their brain it seems like it's moving, and it's very distressing. Many people have photophobia or sensitivity to light. So I'm going to explain why these things happen. But first we should say, how do we normally see? So you guys are looking at me now, and you don't have any problems with vision when the image of me gets transmitted to your right occipital lobe and your left occipital lobe at the same time, and it's the same image. So that's a really key point. You see me, the image goes through your pupil, because that's what dilates. You know, when it's light out, the pupil constricts. When it's dark, like owls have these really big pupils because there's no light. So the image goes through the pupil, goes through the lens of the eye, goes through the fluid, goes to the back of the eye, which is the retina, okay? So when you go to an eye doctor, optometrist, ophthalmologist, they're mostly looking at the physical globe of the eye. So when they say that your eye is fine, they're probably correct. But you're left to be depressed because I got blurry vision, and you're telling me my eye is fine. But you don't see, it's not the retina that sees. Remember I said the image goes to the back of the retina. You don't see till that image goes to the brain, then you see. So you don't see until the image goes to the brain. Well, it turns out the eye nerve highway, the highway that takes the impulses from the back of the retina to the occipital lobe, so when the occipital lobe gets that image, then you see, that's the optic nerve or the eye nerve. So what I'm going to show you is if you have a blockage of the drainage of the brain in the jugular veins and the pressure inside the brain goes up, and you get pressure on the eye nerve from fluid, cerebral spinal fluid, more on the left side than the right side, well then the image gets to your retina at the same time, but the eye highway, the optic nerve, the eye highway is congested on one side versus the other. So your brain is seeing two images, or the brain's seeing three images or four images. And that's why you see and you have blurry vision. So that's kind of a summary of this talk. But now there's lots of different ways that vision is affected. So when you have intracranial hypertension, you can actually get physical pressure on the back of the eye, and the posterior part of the eye gets squished or flattened, and that can increase eye pressure. That's one of the causes of eye pain. Then this is Palinopsia, and that's where you see multiple images. So in my experience, the cause of that is cerebral spinal fluid stasis, which normally is from decreased drainage of the brain because the jugular veins are getting compressed at the atlas. Then that causes, of course, what I just said, that the optic nerve sheath diameter is bigger on one side than the other, so the person's image from the retina, when it gets to the brain, it's delayed, like the right side versus the left side. That's why they see multiple images. When we get the person's cervical structure better, where we get them more of a cervical curve, when they get better stability, so the atlas and the vertebrae don't sublux like when they're reading or when they're doing their computer work, then the brain drains better, the fluid goes off of the optic nerve, then the image goes to the occipital lobes at the same time, then their vision returns. And there's lots of different things. So pulsating vision is where the vision is as if it's pulsating. So another thing that people get is like snow or flickering. Like this patient had, I had blurry vision, double vision, and seeing light crystals that flicker constantly. I also have ghosted images that will follow me when I look away, like the Palinopsia. So in other words, all these snowy vision, blurry vision, double vision, they often have a similar or exactly the same cause, which is, and I'll show you our ultrasounds on people, where the eye nerve is only supposed to have a little bit of fluid around it, but when it has a lot of fluid, it means the fluid in the eye nerve is in a sheath, and obviously the sheath has an enclosed space, much like a person could have a swollen joint and be like, oh my gosh, does my joint hurt? Why? Because the joint capsule is extending, extending, extending. So when there's pressure on a nerve, including the eye nerve, the image gets slowed. The transmission, the nerve conduction of the impulse from the retina to the occipital lobe gets slowed, and of course then, and the image of course can get distorted, right? It can be snowy, it can be blurry, so all these different flickerings. Like I started to get on my right eye, because you guys know I have a little bit, I've had instability on my right side, so I've had flickering lights on my right side. Why? Because there's fluid, or extra fluid around my eye nerve on the right side. So these are the common visual disturbances that, in my opinion, can be from ligamentous cervical instability. Palinopsia, we talked about. Oscillopsia, where there's an illusion of an unstable visual world. The sensation that the surrounding environment is constantly in motion. A problem in which objects appear to jump, jiggle, or vibrate when they are actually still. So in other words, if the image that a person has is unstable, now you might say, well, how could it be unstable? Well, it's like static on a TV or the computer, they're static. You have a clear image that goes onto the back of your eye, which is your retina, but if that image isn't getting to the brain as one whole image, because certain impulses are getting delayed, anything's possible. Snowy image, blurry image, flickering image, pulsating image. So visual snow, we talked a little bit about, like there's dots across the visual field. Photophobia, which is kind of an easy one, that's when the person has their pupils are dilated. So we do a pupillary light reflex test, which we'll talk about. Diplopia is double vision. So double vision normally is the image gets completely fine to the retina, and the accurate image gets to the brain accurately. So, but it's slower on the right side getting there than the left side. So you get a perfect image, but it's double. So say on the left side you get a perfect image, but on the right side the image is slowed. So think about time, it's slowed. So the person, like the Palinopsia where it's a banana. So imagine on the left eye, it's a perfect banana. It goes there and it's a perfect banana. Just exactly how the banana is. Real yellow, da-da-da. But on the right side, because there's so much pressure on the eye nerve, there's many images of the banana getting to the right occipital lobe. Like they might be 0.1 seconds apart. So then, of course, the person sees 5 banana images, and each image is a little bit less clear. Scotoma, an enlarging blind spot in your central vision. So in our office, we don't do visual field defects. We do 3 significant tests that are easily done, reproducible. We check intraocular pressure, pupillary light reflex, and we do optic nerve sheath diameter. If we were going to add a 4th test, it would be visual field defects. So there's people that have blind spot in their central vision or their peripheral vision. Typically, pressure on the eye nerve from the outside would affect primarily the image on the periphery. So that's where people have darkening of the image on the periphery. That's common with intracranial hypertension, pseudotumor cerebri, which we feel in the majority of the cases is from basically chronic venous insufficiency or compression of the jugular veins in the neck, specifically at C1. But there are going to be times where the eye nerve, just because maybe there's symmetric pressure, that the slowing of the image or the inhibition of the image is actually in the center of the eye nerve, and that's where you might get a scotoma. We talked about flickering light, scintillations, and then there's basically kaleidoscope vision, which is interesting, where there's scrambled vision, which can be vividly colorful. Again, I'm just talking about these things can be from a structural problem in the neck. I'm not saying that it's always that, because obviously somebody could have had a stroke of the occipital lobe. They could have vertebral basilar insufficiency or ischemia. So there's definitely other causes. And visual auras are visual sensory disturbances that often predate a migraine. And personally, I think most migraines that people really struggle with, like they have them almost daily, you have to think it's something besides something in the environment. It probably is something structural. And the structural problem normally is upper cervical instability, or at minimum, the atlas and the axis, they're mal-rotated, or in 3D space, they're in the wrong position. This is a patient sent me this. This is basically all of the patient's symptoms, but you see here visual fluctuations, double vision, pressure behind the eyes, blurry vision, nystagmus. But often people have visual problems and they have all these other things. And on this video, I just want you guys to realize, if you have all these other things that are consistent with cervical instability, you have to think like that actually might be the underlying cause of the visual problems. Most people with significant visual problems that aren't due to diabetes, they normally have other symptoms that give clues that actually the problem's in the neck, and they have to get neck treatment. So at minimum, go to an upper cervical chiropractor. At minimum, get a lateral C-spine x-ray to see how your curve is. If the curve is terrible and you have the atlas is way forward, then start on a curve correction program. Obviously, we do that in the office. We called this cat Prolina. Yeah, we called the cat Prolina. See how the pupil is dilated there? So Prolina had a cervical instability problem, but she would never let us treat it. But anyway, so photophobia is probably the most common visual problem that we see here. It's sensitivity to light. The people have sensitivity to light because their pupils are too dilated compared to normal. So sometimes the pupil is extra dilated in one eye to the other. You guys can look in the mirror, see if your black part of your eye is massively dilated on one eye than the other. If it is, then you have a problem on that side. Say your right eye is more dilated than your left, then some vertebrae is probably mal-rotated. Go to a good chiropractor. We don't like people with the upper cervical spine to get so we use an instrument to adjust. The pupil dilates by nerve discharges from the superior sympathetic ganglion. The superior sympathetic ganglion does a lot of things. One of the things that it does is it dilates the eyes, but what often is forgotten is that the vagus nerve can inhibit the superior sympathetic ganglion. So why I like the pupillary light reflex is that it gives me a visual, an objective data of whether or not somebody has sympathetic overdrive. Their sympathetic system is way out of balance to their parasympathetic or their vagus nerve. So when somebody has vagus nerve degeneration, the vagus nerve isn't going to inhibit the superior cervical sympathetic ganglion, and then it's going to do extra discharges to the eye, and then the pupil dilates. So see where you have the superior sympathetic ganglion, it sits right at C2. So these nerves go to the eye and it dilates the eye, the pupil gets bigger. The vagus nerve sends little branches to here to inhibit this. So you might say, well, how is that significant? Well, the adrenaline system is only supposed to be there for the most part for stress. So it's the vagus nerve that keeps the adrenaline system, even in the neck, kind of in check. So if the vagus nerve is degenerated and can't do that, the superior sympathetic system, the nerves, they just keep sending out their stress, danger, so the pupils dilate. Now, you could have a subluxation of C2 on the right here, just irritating that by itself. And of course, that could cause a discharge in the superior cervical sympathetic ganglion. So C2 malrotations are something somebody should get checked out if they have photophobia. And again, we have to remember the nodose ganglion of the vagus nerve and the jugular ganglion of the vagus nerve, they run right by C1. So thus, if somebody has a vagus nerve problem or a symptom that we think is from the superior cervical sympathetic ganglion, and remember the ganglion is where the DNA is, right? The genetic material. So what tells the vagus nerve what to do is going to be wherever the ganglion is, wherever the brains or the genetic material is for that nerve. So the vagus nerve, that's C1, the superior cervical sympathetic ganglion is C2. So if somebody has a photophobia, you got to think, well, maybe it's a problem at the C1, C2 junction. This goes into a lot more detail. There's other nerves that are involved, like the ocular motor nerve and other sympathetic nerves and parasympathetic nerves. But the most common ones that we see in the office on a daily basis is everything is in its shortest position when a person has the normal lordotic cervical curve. Because of cell phones, right? Because of cell phones, everybody's looking down, so everything gets elongated. So everything might be elongated by an inch or two. So what's going to happen to the superior cervical sympathetic ganglion or the vagus nerve if everything's elongated by an inch or two? It may be like danger, danger, danger. There's a major stressor here. Or if it's elongated, so imagine it's elongated, but the C2 is rotated to the right. Then it's going to maybe affect the vagus nerve. Then the superior sympathetic ganglion goes unchecked, and then the person has a dilated pupil. So again, you see this is the eye nerve. So the image goes to the retina, and it doesn't get to the brain until it goes through the optic nerve. So the nerve impulses from the retina get transmitted to the optic nerve, and then the optic nerve eventually makes its way to the brain stem in the brain. This is how we check pupillary diameter. It's called a pupillometer, and it's a computerized device, so that's great because you can recheck a person at a later date. The ideal pupil diameter is normally 4.5 millimeters or 4.6 millimeters or less. The average in our patient population, this is in-house data where we did 138 patients, was 5.2 millimeters, and extreme cases were 36% of the patients. So as a person's cervical curve improves, their alignment improves, and their stability improves, then these numbers go down typically. And then this is just, we can get all kinds of data in a dark room, light room. We can check one side versus the other, and then correlate that with a person's anatomy, and then figure out a treatment program. Common signs and symptoms of raised intracranial pressure. I just want people to realize visual problems are common when the brain pressure is high. And we believe most people, the brain pressure is high because of obstruction or compression of the internal jugular vein, which is the main veins that drain the brain when you're laying down. See, this is the jugular vein, carotid artery. It goes into a different hole, the carotid foramen. The jugular vein goes in the jugular foramen, and see how it goes right by C1. And look at what also is going right by C1 is the vagus nerve. So the vagus nerve and the jugular vein could be getting compressed and the carotid artery not get compressed. Another significant thing is when somebody has an elongated styloid, because the carotid artery is normally medial inside to the jugular vein, it's less likely to get compressed between the styloid bone and the atlas, and that's important anatomy to understand. So if you look here, see how the jugular vein, this is the atlas, see how it's flat here. Remember, it's a vein. It's supposed to be 9 or 10 millimeters by 9 or 10 millimeters. And see, this person has a styloid bone here, but this is getting flattened by the atlas, and on the other side, you see it's getting flattened by the atlas. So those are the jugular veins. That's a CT venogram. And you could see that's clearly the atlas that's obstructing it. So this person needs to have their atlas in a different position. And we do that by curve correction, by adjusting, and prolotherapy. These are just some of the common findings of intracranial hypertension. You can actually see the extra fluid around the eye nerve, which we're going to talk about in detail soon. That's the most common cause that we see for visual problems, such as flickering lights, snowy sensation, increased visual field defects, blurry vision, double vision, oscillopsia, Palinopsia. And then you could see flattening of the posterior globe that can increase intraocular pressure. I should say, when intracranial pressure pushes on the back of the eye and physically flattens the back of the eye, of course, that's increased pressure on the eye, so that can be seen as intraocular pressure. When intraocular pressure is too high, they say you have glaucoma. There are cases in our experience where a person had extremely high eye pressures, like way into the 20s, 28, and then we did prolotherapy, curve correction, adjustments, and the pressures went down to normal. And again, you can even see here, this is the eye nerve. See how this one's all tortuous? Again, that's because of all this white here is the fluid. See all the fluid? Imagine if there's more fluid around the eye nerve on the right eye versus the left eye. Obviously, the transmission of the impulse from the back of the eye to the brain could be slowed. And it's that slowing that gives blurry vision or multiple vision. This explains in more detail about if you have increased superior cervical sympathetic ganglion activity, and it can cause all these things. It can cause exaggerated pupillary hippus. You can have intracranial pressure go up, and of course that can increase eye pressure and cause, in my opinion, all kinds of things: optic neuritis, blurry vision, compression of the eye nerve. If you have glaucoma, macular degeneration, retinopathy, and nobody knows the cause, you really might want to have your neck looked at. We talked about light sensitivity. And then, of course, early on, I talked to you about, like, if the ophthalmic artery gets closed, that you actually could lose vision on one eye. And this is basically in more detail about how ligamentous cervical instability can affect the various nerves that are in the brain or that run in the neck. And then that has so many different effects. That can affect eye tracking, it can affect vision, and actually, in my opinion, cause structural problems inside the eye itself. And then when we talk in our office about neck vitals, if you look at them, there's quite a few that relate to the eye. We do optic nerve sheath diameter, so that's obviously the diameter of the eye nerve and the fluid around it. Pupillary light reflex we talked about, and then intraocular pressure. So intraocular pressure, just like an ophthalmologist would do, we check pressure. The normal eye pressure is 10 to 15. The normal brain pressure is 10 to 15. The only place that we can really see the brain, inside the brain without sophisticated equipment, is the eye. The eye is actually in the brain, so they have exactly the same pressure. So to me, eye pressure is a good indicator in most people as far as what's going on in the brain. So if the eye pressure is high, there's probably a good chance that the brain pressure is high. And in the office, when we talk about jugular vein compression, we can put a person through various positions and look at, does the jugular vein, this is an open jugular vein, and you can see down here with a certain position, you can't even see it. Obviously, if a person's laying down like they're going to bed, we have them in their sleep position, and if it looks like this, it's not going to be good for that person or that person's eye, because during the night, let's be honest, like, the brain washes itself, the eye tries to cleanse itself, there's a lot of circulation, the brain, the eye is trying to get rid of toxic stuff in it. So there has to be the free-flowing fluid into the eye, out of the eye, into the brain, out of the brain. And if the main drainage port of the brain is all clogged up, it's like this, well, what's going to happen? The toxins don't go out of the eye, toxins don't go out of the brain, and you start getting brain disease and eye disease. Now this is what we do with optic nerve sheath diameter measurements. This is kind of like more normal, and you could see where this eye nerve with this fluid around it, it's like twice the size. Let's say this was actually the same person and they both have an image going to the retina that's normal. This would get to the brain at the normal speed, so they have a perfect banana. Where this one, it would be slowed, so you might see one banana with white spots on it, or flickering, or several banana images that come one right after the other because the image is so slowed to get there. So basically what the person will do is will see multiple images. So one thing the person can do is, in that particular case, is close your right eye. Then your left eye is the image pretty good. So if the image is pretty good, then you know that the problem's mainly in the right eye. So that's a way also to determine which eye is the problem. Like I recently saw a chiropractor who, I was going over the test results, blah, 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 and they had this kind of a thing on the left eye, their left eye. And they said to me, oh my gosh, for years I've noticed my focusing, my ability to see with my left eye is definitely less than my right eye. So they hadn't even said that in the history. So that's kind of cool, where there was confirmation that the problem was that they were getting compression of their jugular vein. And that particular person had a forward C1, and they also had a styloid on the left side. And they also, as part of their history, they had learned that if they turn their head to the left, that they get vertigo. So and the person's a tennis player. So they learned over time that they can't quickly turn their head to the left. Well, because I showed them that they had this elongated styloid, that when you turn your head quickly to the left, that was compressing the jugular vein, which would affect pressure in the brain really quickly, and then of course you can get vertigo. So how do we put this all together? In our office we do a digital motion x-ray, so it's upright x-ray, and then we have them move their neck and their head, and we can see whether they have instability. So there are people that just have cervical instability, their alignment's very good, their curve is good, they just need prolotherapy to tighten the ligaments. There's other people where they really don't have instability, but they have terrible misalignments and they have terrible curves. So those people, they mainly need chiropractic care, they need adjustments for their alignment, and they need curve correction. Most people fall in the category they need both. They have some instability and they have some misalignments, some changes in their cervical curve, which I term cervical destructure, where there's a breakdown in the cervical curve. Some people have elongated styloids. We've had people where they have a terrible compression of the spinal cord, which is called myelomalacia, that you see on MRI, like it's just getting strangulated, and they have all kinds of leg symptoms from their neck. They need a decompressive surgery. And other people, physically, emotionally, or spiritually, they need to get that in order. Sometimes the primary thing the person needs to do is do some work spiritually and emotionally and be in a good place. So if they're going to do an extensive, prolotherapy treatment regime or extensive chiropractic, they're in a right place for it. They're in a right place for healing. And somebody who knows who they are, they love God, they're loved, they love other people, they're going to heal a lot better anyway. So all of us really should always be trying to intentionally get our faith stronger, our friendships stronger, our self-esteem stronger, be giving. And there's some people, they suffer so much. They come to my office and you would be amazed at the joy they have. So they're just, as people, they're just unbelievable. And maybe they should be role models for the rest of us. So I hope this is helpful. I'm going to do more videos on the eye, but I hope this is just a kind of a good overview video and gives you hope that if you have trouble with your vision, like you're really distraught about your vision, that this will give you insight into things that are correctable, even things that you can do at home, like get your curve good, maybe see an upper cervical chiropractor, and obviously us at Caring Medical, we're always there to help you.